Welcome to a webinar about research evidence related to facility standards for outpatient office-based procedures, including abortion. My name is Dr. Sarah Roberts. I am an associate professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Francisco. I study the ways that policies in our healthcare system punish rather than support structurally vulnerable pregnant people. And I specifically study policies related to substance use during pregnancy and policies related to abortion. I have a master's from the University of Michigan, a doctorate from the University of California, Berkeley, and that doctorate is in public health. And I'm joined today by two additional speakers, Dr. Alicia Schwartz and Sarah Daniel, and I will let them introduce themselves.
Hi,
Dr.
thank
Schwartz.
you, Sarah. Thank you, Dr. Roberts. My name is Alicia Schwartz. I am a pediatric nurse practitioner. I got my master's training from Columbia University, and I am a doctorally prepared nurse scientist, and I was trained at the University of California, San Francisco. I specialize in pediatric and adolescent sexual and reproductive health. I am an assistant professor at the California State University East Bay, and I am their pediatric specialist. My research is primarily focused around expanding sexual and reproductive health training of nurses in the United States, as well as expanding their training to include abortion care. Thank you.
Hello, everyone. I'm delighted to be here with all of you today to share our research findings. My name is Sarah Daniel. I have my master's in public health from the University of Illinois at Chicago, and I've been a research and project manager at the University of California, San Francisco for the last 8 years, working on various research projects evaluating the California State Family Planning Program, to looking at access to contraception and abortion. And I'm currently a doctoral candidate in epidemiology at Johns Hopkins University.
Thank you. In terms of our webinar today, we have 3 learning objectives. These include to list public health and nursing professional values that are relevant to abortion-related work, including abortion-related work in health departments. Explain the ways that state laws single out abortion facilities for regulation, and describe the evidence base for facility standards for outpatient office-based procedures, including abortion. Over the next hour, we will provide information about the context and background for what we're going to be talking about today, provide some basic Abortion 101 information, talk about nurses and nursing values related to abortion, present research, legal epidemiology research about state facility laws on non-hospital-based outpatient procedures, share research findings about the evidence base for facility standards, talk about the future of abortion facility regulation, and then have time for questions. Abortion is currently legal in the United States. It became legal throughout the United States in 1973 with the Supreme Court case Roe versus Wade. Prior to Roe versus Wade in 1973, abortion was legal in some states. What Roe versus Wade did was make it legal throughout the United States. However, when we're talking about abortion policy in the United States, it's not just a question of legality. In many parts of the country, there are a limited number of abortion clinics. This map here shows you how far people live from the nearest abortion facility. The parts in blue on the map show places where people live within 12 miles of the nearest abortion facility. And the places in red show where people live more than 100 miles from the nearest abortion facility. You can see from this map that there are significant parts of this country where people live more than 100 miles from the nearest abortion facility. Again, it's not just a question of legality in relation to abortion. There are many state regulations on abortion in the United States, many of which have been in place in some states for close to 40 years. In more than 2/3 of states, there are restrictions on use of public funding to pay for abortions for low-income people. Even more states require parental involvement for a minor to be able to have an abortion. And more than half of states require people to wait between 24 and 72 hours in order to be able to have an abortion. Over the past decade, we've seen a dramatic increase in the number of state-level restrictive abortion policies. Between 2011 and 2016, there were about 30% of all restrictive abortion policies in the United States were enacted during this time period. During this time period, we also saw a change in some of the types of restrictive abortion policies that exist. We saw a dramatic increase in the number of states that have targeted regulation of abortion provider laws, which Sarah Daniel will talk about a little later, and I will provide the research evidence underlying these towards the last third of the presentation. Something important to know about these targeted regulation of abortion provider laws, and part of our motivation for being here today, is that many of these targeted regulation of abortion provider policies are implemented through the health department infrastructure. And health department commissioners in some cases are defending these regulations in court. Usually when we talk about abortion, we talk about it as a political topic, a personal topic, a moral topic, or a legal topic. What we're going to do here today is begin to shift to talking about it as a healthcare topic and a public health topic. All of us, including our panelists, have personal views on abortion. It's almost impossible to live in the United States without having some personal or political views on the topic. Our goal today is to begin to identify what some of those professional values and frameworks are that can guide our thinking about and our approaches to abortion. Some suggestions for frameworks to use to guide us in our thinking about how to approach abortion as a health professional include use of professional frameworks, such as public health frameworks related to the essential public health services, or evidence-based public health practice, or in terms of nursing, as nursing standards of practice. I'm now going to turn this over to Dr. Swartz.
Thank you, Sarah. So I wanted to start by first providing a pretty brief overview of abortion care in the United States, and then also lead us to think a little bit more about the role of nurses in abortion care. Next slide, please. So we'll start off with a little bit of Abortion 101. Next slide, please. So this chart is showing the current breakdown regarding the timing of abortions performed in the United States. And as published in 2019, the majority of abortions performed, approximately 9 out of 10 abortions occurring in the United States, were performed during the first trimester of gestation. And the majority of those abortions, as you can see here, are actually occurring before 8 weeks of gestation. And so it's important to point out that a very small percentage, approximately 1% of abortions performed, occur after 20 weeks of gestation. Next slide, please. And so when we think about the majority of abortions being performed and where are they being performed, we want to think about the type of facility that's being used. And while about a third of the facilities in which abortion was provided in 2017 were hospitals, it's important to point out that the majority, about 95%, were provided in non-hospital-based clinics. So this includes both specialized abortion clinics, and it also includes non-specialized clinics. Specialized abortion clinics, in this case, which account for the majority of abortions being performed, are clinics that are defined as facilities where half or more of the patients have received specific abortion care. And so when we think about this slide and we think about the majority of abortions actually being provided in non-hospital-based clinics, it's important to think about how the procedure itself is dictating the setting. And it makes sense that abortions, which are typically outpatient procedures or medication dispensing, it makes sense that these visits occur in an ambulatory, non-hospital-based setting. Next slide, please. So what are the different types of abortions? Currently in the United States, there are 4 legal types of abortion methods. The first being medication abortion, and this involves the use of medications to induce uterine contractions that are intended to expel the products of conception. And this regimen is approved by the FDA for up to 10 weeks of gestation. Just recently, it's also been approved for up to 11 weeks of gestation. And it uses 2 medications, mifepristone and misoprostol. And there's these medication abortions account for the vast majority of abortions that occur here in the United States. Second, there are an aspiration abortion procedure, which is also referred to as a procedural abortion or a surgical abortion. And this procedure is approved up to 14 to 16 weeks of gestation. And it's performed using a hollow curette tube that is inserted through the cervix and into the uterus. And at the other end of that tube is either a handheld syringe or an electric device that applies suction, and that suction is used to empty the contents of the uterus. The third procedure is called dilation and evacuation. And this is usually performed starting at 14 weeks of gestation. And this procedure involves a cervical preparation with either osmotic dilators and or medications, followed by suction used to empty the contents of the uterus. And with this particular procedure, ultrasound guidance is often used. And finally, there's the procedure of an induction abortion, which involves the use of medications to induce labor and delivery of the fetus. And the most effective regimens in terms of the medications that are used to induce labor use a combination of mifepristone and misoprostol. I want to point out, though, that abortions occurring during the second trimester are very rare and are the least practiced procedures here in the United States. Next slide, please. So, abortion is safe. In 2018, the National Academy of Sciences, Engineering, and Medicine published a report on the safety and quality of abortion care in the United States. And from those findings, they were able to demonstrate with decades of evidence that legal abortion in the United States is safe, and that less than a fraction of 1% of the majority of abortions in the United States resulted in a major complication. So complication is rare and abortion is safe. One of the more important findings that they found during their research is that one of the main indicators that reduced the quality of abortion care in the United States was really restricted to state-level restrictive abortion policies. And so it was these state-level laws and policies and additional unnecessary regulations that were placed around abortion procedures and abortion facilities. These policies tended to contribute to delays in abortion care, and they also made abortion care less patient-centered. Next slide, please. So let's think about, well, what is the role of nursing in abortion care? One of the things that I like to always point out is that when we think about the role of nursing in women's health care, that spans the lifespan. And we think about the role of advanced practicing nurses in reproductive health care. We're thinking about midwives and adult nurse practitioners. Their care also expands the lifespan, and it's involved in birth, sometimes involved in fetal demise, and then also involved in abortion care. So next slide, please. I want to talk a little bit about some of the background about nurses and abortion care. In the United States, abortion counseling was really codified in the laws associated with abortion care. And as a result of that, there has been an entire years of graduating classes in the healthcare workforce, which is undertrained or not trained at all in options counseling or in the provision of abortion care. Additionally, the role of nurses in, for example, pain management or in sedation practices has become very specific and has been limited to a very finite role under the regulations of ACOG and also federal guidelines. So it's important to think about, well, why are these practices for nurses so restricted? Why is there a lack of training among nurses? Why are they being undertrained in options counseling and abortion care? And really, it's really an issue of the education required to be really competent in clinical practice. And so in particular, schools of nursing began in hospitals, many of which were religiously affiliated. And it was not until some very intentional investments by the US government in nursing education in the late 50s and 60s that schools became affiliated with universities. And this was done in efforts to increase and improve the professionalism of nursing. In fact, this is one of the contributions that lack of professional training from using evidence-based scientific practice was one of the ways in which the development of expert nurses was limited and then became expanded with their affiliation with universities. And so we developed a sort of a cohort of expert nurses in abortion care provision. And then given that most of the abortion care in the United States is delivered in an outpatient or ambulatory setting, that full integration of caring for people seeking abortions has been developed by those outpatient facilities and has historically been driven by very specific site-specific protocols and procedures. Another limitation on education required for providing evidence-based practice in abortion care is the NCLEX, which is the primary licensing exam for registered nurses, and that sets the standards for the minimum competence to perform the broad duties of nurses. This exam remains focused on acute care settings and the care of patients in inpatient hospital settings. Currently, there are 5 broad areas that nursing programs teach to, as well as are tested using the NCLEX: medical surgical nursing, pediatrics, community health, psychology, mental health nursing. And then there's also nursing of childbearing families or maternity nursing. The content in sexual and reproductive health is typically considered optional content for most nursing programs, as it is not one of the primary focused sections on the NCLEX exam. And so that limits the training that's received in educational settings. That lack of educational exposure and that limited training in providing ethically challenging care makes it difficult for nurses to go out into the field, feel comfortable with abortion practices, feel comfortable in an abortion clinical setting, and also feel comfortable providing evidence-based options counseling to vulnerable pregnant women who may be interested in abortion. Next slide, please. So in thinking about this lack of training and thinking about the role of nurses in abortion care, I thought that it was important to highlight some recent research that is published this year that I've been working on, which really was a survey of a representative sample of registered nurses here in the state of California. And it was a survey that was conducted following the passage of several Assembly Bill laws in California that expanded nursing practice to improve patient access to abortion care as well as contraceptive care. Particularly, one of these laws expanded the scope of registered nurses to be able to dispense and provide hormonal contraceptives to patients without the need of a prescribing clinician. And they could continue to provide this service for up to 3 years without the need of consult of a prescribing clinician. The other two laws were really intended to remove some of the infrastructural regulatory barriers to the provision of abortion care. And they really allowed for advanced practicing nurses or nurse practitioners to be able to provide first trimester aspiration abortions. Next slide, please. So from that study, what we found was that understanding about the current attitudes about abortion care among nurses really informs how we make plans for nursing education, our workforce development, and other training needs. And we found that, in particular, the attitudes of our participants were in some ways really conflicting and or contradictory in terms of their beliefs around abortion care. All things ranging from some nurses on the one hand feeling that abortion should not be legal, and at the same time, on the other hand, also believing that abortion is an effective, safe, and evidence-based method for addressing unintended pregnancy. So a lot of conflicting beliefs, and we also found that there were some specific demographics that influenced those beliefs, namely those identifying as Christian were more likely to be anti-abortion, and those identifying as either white or Caucasian were more likely to be pro-abortion. And so I was particularly interested in thinking about the training. And so when sampling, looking at the sample of pediatric nurses in particular, they often felt like they lacked training in sexual and reproductive health. They lacked training in their ability to be able to provide contraceptions or provide STI screening. And most surprisingly enough, were also unaware that it was within their scope of practice to provide these services. And these findings in terms of the lack of training, the lack of comfort with provision of care, and the lack of awareness around what actually is the scope of practice of a registered nurse and or an advanced practicing nurse, a nurse practitioner, this was sort of pervasive across all of the different fields of nursing. So it wasn't just limited to the pediatric nurses. This was found in adult nurse providers as well. Next slide, please. This is sort of looking at some of those statistics in terms of the awareness around the scope of practice and their comfort with sexual and reproductive health, as well as their need for additional training to feel confident in providing sexual and reproductive health care. Next slide, please. So we've sort of, at this point, I've highlighted that there is, in general, a lack of training, and given some historical context to why that lack of training exists, and also the continuing expanding of scope of practice for nurses across the United States. Several states have started to expand the scope of practice to improve individuals' access to sexual and reproductive health care. But I also think it's important to point out that the American Nurses Association has published some ethical standards of practice. And one of those standards I wanted to highlight in our talk today. And it basically says that nurses must examine the conflicts arising between their own personal and professional values and the values and interests of others who are responsible for patient care and healthcare decisions. So really, this is calling for nurses to really address these personal conflicts that they have in ways that will ensure patient safety and promote the best interests of the patient. And so we're thinking about using appropriate evidence-based practice, addressing our own personal and professional views, and getting around this idea of nurses really needing to be better trained in how to provide ethically challenging care as their scope of practice deems them to do so. Next slide, please. And so that brings us to thinking about, as a nurse, given our lack of training in nursing school, given the lack of emphasis around sexual and reproductive health on the NCLEX exam that dictates the type of training that we receive in our nursing education training programs, it's mostly expected for most registered nurses to have little to no exposure to abortion facilities, or little or no exposure to abortion practices themselves. And therefore, it's hard to develop sort of a professional basis for understanding abortion care and also going in and doing an inspection of those abortion facilities. And so I really wanted to point out today that understanding the practices that each facility uses is really the basis for inspection of that facility. Abortion practices are typically carried out in non-hospital-based settings. And so these are community health clinics, outpatient ambulatory clinic settings. They have a functioning laboratory. They have an exam room. The regulations and the standards that are associated with that facility type are really dictated by the type of procedure being performed. And so it's crucial to think about what is the type of procedure being performed, and what are the safety and regulations that are needed in order for that procedure to occur in an evidence-based and safe manner. Next slide, please. And so when we're thinking about our professional role, it's really important to fall back on the decades of evidence that have been used to design the protocols and procedures in abortion practices. And this type of evidence is used to inform the type of setting required. Similar to any other outpatient procedure, the equipment needed, the emergency equipment needed, the structure of the lab, the clean spaces versus dirty spaces, the autoclaving of equipment, sterilization of the facility, all of those things are dictated by the specific protocol and procedure within that outpatient setting. So I wanted to provide this picture today because this is an example of a typical exam room in an abortion clinic. As you know, this is very different from what we would see in obstetrics and gynecology unit of a hospital, or a labor and delivery unit of a hospital. Very different from what we would see in an operating room. This is an outpatient setting, and so the regulations really need to be in support of maintaining that setting to provide the most patient-centered care and the best evidence-based practice. So thank you for letting me share that with you today. Next slide.
Great, thank you so much, Dr. Schwartz. So today I will be sharing our study objective and methods and research findings looking at state laws, state facility laws. Next slide, please. So our goal is to compare state laws regulating abortion facilities, which I will refer to as TRAP laws, or targeted regulation of abortion providers, to state laws regulating office-based surgeries, procedures, sedation, or anesthesia generally. And I will refer to these as OBS laws. And just to clarify, when I use the term facility laws here, I refer to the laws that govern a healthcare practice's organizational or business operations and its physical environment. And we do not include or examine laws governing actual clinical practice. Next slide, please. So In partnership with the Temple University Policy Surveillance Program, we used policy surveillance methods to conduct cross-sectional legal assessments of state facility laws in the 50 states and the District of Columbia as of August 1st, 2016. And unlike traditional legal practice, which is based on interpretation of legal rules and precedent, our coding questions sought to identify and record only observable features of the laws. And this helps ensure the validity and the reliability of our data. So we developed search strings and conducted keyword searches on legal databases, including Westlaw, to identify and record citations of relevant statutes and regulations. And each of the laws were coded by two trained attorneys and were across a defined set of measures, which I will discuss shortly. And the discrepancies between the coding were reviewed and resolved. And we used chi-squared and Fisher exact tests to compare requirements between states with OBS laws and those with TRAP laws. Next slide, please. So based on a review of a sample of facility laws, we developed these measures of facility requirements. So in particular, we looked at the applicability of laws, so whether it is by type of procedure or level of sedation. We looked at requirements that facilities be licensed by the state or be accredited by an accreditation body. We also looked at various physical plant requirements, including specialized room requirements and various physical plant specifications that are listed here. And we also looked at clinician qualification requirements beyond appropriate licensing and training, requirements for various policies and procedures, and requirements for patient hospital transfers, including requirements for hospital admitting privileges and transfer agreements. And finally, we determined the nature of penalties authorized for noncompliance in each law. Next, please. So today I will present our findings on the measures that you see listed here. Next, please. So in terms of our findings, the prevalence of laws, I'm going into the prevalence of laws. So 25 states have enacted 25 OBS laws, and only one state, Maryland, has a facility law governing specific procedures other than abortion. And that law regulates facilities that provide cosmetic surgical services using moderate sedation or greater. Next, please. In terms of abortion, 34 states have enacted 55 TRAP laws. And as you can see here, some states have more than one TRAP law, and that's the number in parentheses. And that's because we identified three different types of TRAP laws. So those requiring abortion providing facilities to be licensed using an abortion facility licensing scheme or meet state regulations specifically for abortion facilities. Those requiring abortion providing facilities to be licensed as ambulatory surgery centers or meet state regulations for ASCs, and those requiring that abortion providing facilities be licensed as hospitals and meet state hospital regulations. And because the hospital laws, specifically in the first trimester, have been declared unenforceable, we did not include those laws in our comparison of specific requirements. Next, please. So moving into our findings, in terms of the applicability of laws, 92% or 23 of the 25 OBS laws apply to facilities based on the level of sedation used. And as you can see here, the majority of laws apply based on use of moderate sedation or greater. However, none of the TRAP laws apply based on the level of sedation used. Next slide, please. And that is because TRAP laws are triggered by the provision of abortion. And as you can see here, only 12% or 3 out of the 25 OBS laws apply to facilities regardless of whether they provide any procedures or surgeries. And most of, as we just saw, those are triggered by the level of sedation. And conversely, 80% or 44 out of the 55 trap laws apply to facilities regardless of the nature of the abortion being performed. So that means that these laws apply to facilities that provide medication abortion, even if they have no procedures or surgeries at all. Next slide, please. So for the rest of our findings, I will be focusing on the 17 states that have a trap law as well as an OBS law. So in states that have multiple trap laws, we used the least onerous requirement and excluded the most onerous requirement in our direct comparison. Next, please. So first, we look to see if these states required regulated facilities to obtain a state license or accreditation from a third-party accrediting body. So 11 of the 17 states do not require licensing or accreditation in their OBS laws. On the other hand, 16 of the 17 states required abortion facilities be licensed with the state. So this suggests that state regulation of abortion facilities is more direct via state inspection and licensing. Next, please. So this more direct regulation of abortion providers also emerges in the penalties imposed against a person or facility for violation of the law. So again, 13 of the 17 states did not specify penalties in their OBS laws, and by contrast, nearly all states authorize penalties for non-compliance in trap laws. Next, please. And you can see closely here that 14 states authorize harsher penalties in their trap laws than in their OBS laws, and only one state authorized harsher penalties in their OBS law. Next, please. So moving on to specialized room requirements. So some facility laws, and Alicia alluded to this earlier, permitted office interventions to be provided in an exam room. Other laws required procedure room or operating room for that purpose. And procedure rooms are typically larger than exam rooms, and operating rooms are larger still and are usually equipped with, to maintain a sterile environment and accommodate more extensive equipment and additional personnel. So some facility laws permitted patients to recover in the room in which they received an office intervention, and other facility laws required that facilities provide a separate recovery room separate from the exam room. States are significantly, as you can see here, less likely to specify requirements for specialized rooms in their OBS laws than in their trap laws. And in particular, trap laws are more likely to require a procedure room than in OBS laws. Next slide, please. In terms of physical plant requirements, some facility laws establish specific dimensions for width of facility hallways or doorways. Other laws require that such openings be adequate or for the purposes served, or impose no requirements in this area at all. And for specific physical plant requirements, while we did not find any significant differences in trap laws and OBS laws, a handful of states do require hall or door widths in their trap laws. Next, please. So some facility laws require the establishment or of arrangement related to transferring a patient to a hospital if needed. And this figure shows requirements for patient transfer agreements from the most onerous at the top to the least onerous on the bottom. So therefore, for each law, we coded the minimum requirements for patient transfer agreements. So for example, if a law required transfer agreements or admitting privileges, we would code that as a transfer agreement, as it's the least onerous of the two requirements. So here you can see that trap laws require the more onerous requirement that OBS laws do. Next, please. So of the 17 states that have both OBS laws and trap laws, 76% or 13 of the 17 imposed stricter facility requirements on abortion facilities than facilities providing other office interventions. And you can see here, southern states are more likely to impose stricter TRAP regulations that include licensing requirements, specialized room and physical plant requirements, and greater penalties for non-compliance. Next slide, please. So just for some concluding remarks, first, states frequently singled out abortion provision for targeted regulation, enacting more TRAP laws than OBS laws. And as Alicia and Sarah have alluded, it is important to note that abortions are a small subset of office interventions with an established safety record. And at the same time, states had virtually never singled out other office interventions for separate legal treatment, and only one state law that targeted particular procedures other than abortion, and that was for cosmetic surgery. Secondly, TRAP laws impose more numerous and more stringent requirements than OBS laws and regulate abortion facilities in a more direct manner via state inspection and licensing. And finally, our findings suggest that TRAP laws go beyond the necessary and accepted standards of practice without providing benefits. And Alicia also mentioned this earlier, that other studies have actually shown that they decrease access to timely abortion care. Next slide, please. So I just want to share a few resources with you. The first is a publication of these findings in the American Journal of Public Health. And we also have supplemental materials on the AJPH website where you can access the coding for each of the laws. And secondly, I want to direct you to lawatlas.org. This is the Temple University Policy Surveillance Program website where you can access maps, tables, and data on this topic and a variety of other public health topics. Thank you so much.
Thank you, Sarah. So far you have heard about the ways that abortion is singled out for more onerous regulations, as well as heard about the nursing and public health values that should be guiding work on this topic. And one of those values includes looking at what evidence-based practice looks like. So what I'm going to share with you next are a series of research studies that we conducted to look at what the relevant evidence base was to thinking about facility standards for abortion facilities, and to look at how standards for abortion facilities would be developed if they were based in the best, available evidence, but also if they were developed similar to the way that facility standards are developed for other outpatient procedures. Specifically, I'm going to share research with you that describes the existing evidence base related to facility standards for non-hospital-based outpatient procedures in general. Share findings from new research that begins to build an evidence base related to facility standards in the context of abortion, and then describe how facility standards would be set for abortion if abortion were not singled out. The first study we did was led by my colleague, Dr. Nancy Berglass. And for this study, we conducted a systematic review that looked at the effective outpatient setting, ambulatory surgery center versus office, on patient safety, service availability, and patient satisfaction for non-hospital-based outpatient procedures. The second question looked at the effects of specific facility factors on patient safety, service availability, and patient satisfaction for non-hospital-based outpatient procedures. The specific facility factors we looked at were the types of facility factors that Sarah talked about in the previous presentation. And part of the reason that we looked at ambulatory surgery center requirements was because that is a type of TRAP law that often exists to require abortions to be provided in ambulatory surgery centers. And for this systematic review, we looked broadly at non-hospital-based outpatient procedures and did not restrict our research and our review to abortions. Specifically, we looked at ambulatory surgery center versus office, accreditation, emergency response, physical plant, staffing, and required policies. We used standard systematic review methods, including defining our research questions, developing search terms, registering our protocol, having clear inclusion-exclusion criteria, conducting title and abstract review by 2 independent reviewers, reviewing the full text of included studies, including assessing the risk of bias of these studies, and then extracting data from the studies that met minimum quality standards and synthesizing findings. For the first research question that looked at whether there was evidence about differences between procedures in ambulatory surgery centers versus office-based settings, we identified close to 1,500 possible articles to review. After reviewing the titles and abstracts, as well as full text articles to see whether they met our inclusion criteria, we identified 10 studies that we were able to include in our synthesis. 7 of these studies met the minimum quality criteria. 5 of them compared patient safety outcomes across facility types. 1 reported mixed findings. 3 reported greater risk in procedures in ASCs than office-based settings, and 1 did not assess statistical significance. 2 compared patient satisfaction across facility types. 1 reported mixed findings, and 1 found no statistical difference across settings. 1 examined a state-mandated ambulatory surgery center requirement for abortion and found a decrease in abortion service availability. For the second question, which looked at specific facility requirements, we identified more than 2,500 possible articles. After reviewing these titles and abstracts, as well as full text of a subset of the articles, we identified 12 articles to include in our synthesis. However, most of these articles did not meet minimum quality criteria. Of the 3 studies that met minimum quality criteria, 1 examined the effect of facility accreditation on patient safety and found 1 statistically significant finding out of 20 comparisons. 2 addressed the effect of emergency response protocols on service availability and found that requiring abortion providers to have hospital admitting privileges, so 1 example of a trap law, resulted in the decreased availability of abortion services. So from this systematic review, we were able to conclude that existing research does not indicate a difference in patient safety for procedures in ambulatory surgery centers versus office-based settings, and that there's insufficient research to draw conclusions about the effect of specific facility requirements on patient safety. However, the review also found that requiring abortion providers to have admitting privileges or requiring abortion facilities to meet the standards of ambulatory surgery centers is associated with a decrease in service availability. The next 2 studies that I'm going to tell you about examine whether facility type is related to the safety of abortion and then to the safety of miscarriage treatment. For this study, we used the Truven Health Market Scan database, which is a national insurance claims database of about 50 million privately insured patients. The facility factor that we looked at was ambulatory surgery center versus office-based setting. Our primary outcome was abortion-related morbidities and adverse events. Our secondary outcomes included major abortion-related events and infections. We controlled for possible confounders, conducted data analysis using generalized estimating equations, and conducted a series of sensitivity analyses to see whether our findings changed when we made different assumptions. In terms of inclusion criteria, the abortion needed to be in an ASC or an office-based setting, and the person needed to be enrolled for 1 year prior to the abortion so that we would be able to have sufficient data to control for potential confounders, and then 6 weeks after the abortion so that we could detect any abortion-related morbidities and adverse events. We used a very rigorous process to code the outcome. We looked at all diagnoses and treatments within 6 weeks subsequent to the abortion. We had a nurse clinician coder who was blinded to facility type, who manually coded all ED visits, all abortions that had an ED visit within the subsequent 6 weeks, all visits with an abortion or miscarriage complication diagnosis code, and all abortions that had an inpatient encounter within the 6 weeks subsequent to the abortion. And then we programmed in repeat procedures and additional doses of misoprostol, IV antibiotics, missed ectopic pregnancies, and major events. We use the PAIRS framework to guide our coding of the outcomes, and I want to highlight the definition of major abortion-related morbidities and adverse events that we used. And this definition is consistent with what the National Academy of Sciences, Engineering, and Medicine used in their report on the safety and quality of abortion care. For our study, major events included those that resulted in an overnight hospital admission, a surgery, or a blood transfusion. Our data set included more than 50,000 abortions between 2011 and 2014. About half were first trimester aspiration abortion, about 25% first trimester medication abortion, and another quarter second trimester or later abortion. About 90% took place in office-based settings, and about 10% in ambulatory surgery centers. In terms of what we found, this is the adjusted incidence of abortion-related morbidities and adverse events, which we call events for short, by facility type. We found that overall, and this is consistent with previous research about the prevalence of abortion-related complications or abortion-related morbidities and adverse events, that about 3.3% of abortions resulted in any morbidity or adverse event, and less than a fraction, or only a fraction of 1% resulted in a major event. So 0.3% resulted in a major event. And again, less than 1% resulted in an infection. What's important when we come back to our research question, though, is that we found no statistically significant difference in any events, major events, or infections after abortions between provided in office-based settings versus ambulatory surgery centers. When we separate this out by the type of abortion, and if we go back to Dr. Schwartz's presentation earlier, first trimester aspiration abortions and first trimester medication abortions are the most common types of abortions in the United States. We found no differences in abortion-related morbidities and adverse events between abortions in office-based settings and ASCs for first trimester aspiration abortions and then second trimester and later abortions. We did find more events after medication abortions in ASCs and office-based settings, but as I'll point out on the next slide, there were very, very, very few medication abortions provided in ambulatory surgery centers, so that finding should be interpreted with caution. In terms of what to take away from this, there was no statistically significant association between facility type and abortion-related morbidities and adverse events. It's important to have caution in interpreting the medication abortion finding, as medication abortions in ambulatory surgery centers are only 0.3% of the sample. I do note that there are some questions about generalizability, as only 15% of abortions in the United States are paid for by private insurance, and this was a private insurance claims database. Notably, though, the safety of second trimester and later abortion also did not differ across ASCs and office-based settings, and overall, the safety of abortion did not differ across ASCs and office-based settings. We then looked to see whether we would find a similar pattern of findings for miscarriage treatment. The reason that we selected miscarriage treatment is that the procedures and medications used to treat miscarriages are very similar to the procedures and medications used for abortions. We used essentially the same study design with the exception that we used to look at abortion The difference was that we also included hospitals, and we did that because, unlike with abortion, most miscarriages today are still treated in hospitals. And also because, unlike abortion, there had not been a significant body of research comparing the safety of abortion in hospitals versus outpatient settings back in the 1970s and 80s. So again, we use the same database, and the only difference in our methods was that we also included a hospital as a setting. And so we compared hospital versus ambulatory surgery center versus office-based setting. We had very similar inclusion and exclusion criteria. Again, the only notable difference was that we also included miscarriages treated in hospitals. We again used very similar methods for coding our outcomes. The only difference was that we slightly reduced the manual coding by having identified diagnosis and treatment codes that indicated a morbidity or adverse event that we were able to use to decrease the number of lines of the database that we needed to code manually. So we had close to 100,000 miscarriages treated between 2011 and 2014. About 2/3 were first trimester procedures for pregnancy loss, 2% were second trimester procedures for pregnancy loss, 16% were procedures for septic or incomplete miscarriages, and 15% medication treatments. About 3/4 were performed in hospitals, about 15% in office-based settings, and 10% in ambulatory surgery centers. We had 2 different statistical comparisons in this study since we needed to compare ASCs to office-based settings, actually 3 comparisons, and then hospitals to ASCs and to office-based settings. The star indicates when the comparison to office is statistically significant, and the cross indicates when the comparison to ASC is statistically significant. What we can see here is that when we look at any events, miscarriages treated in an office and a hospital had similar proportions resulting in any morbidity or adverse event, and fewer abortions in ASCs than in hospitals or offices resulted in any morbidity or adverse event. When we look at major events, what we see is that there were no differences in major events between office-based settings and ambulatory surgery centers, but there were more major events after miscarriages treated in hospitals than either in ASCs or office-based settings. One of the other things to note from this slide is that the incidence of events was higher for miscarriages than for abortions. When we look by procedure type in terms of how the miscarriage was treated, we see no differences in the incidence of events by ASC versus office-based setting for first trimester procedures, second trimester procedures, or incomplete or septic procedures. So no differences for miscarriages treated with procedures between office-based settings and ambulatory surgery centers. We did see more events for miscarriages treated with procedures in hospitals, though, than we did in either outpatient setting. In terms of miscarriages treated with medication, we see more, or we see fewer events after miscarriages treated with medications in ASCs versus offices, and with hospitals versus offices. So we note that there were some statistically significant associations between facility type and miscarriage treatment related morbidities and adverse events. We found that events were as or more likely to occur after miscarriages treated in hospitals than either ambulatory surgery centers or office-based settings. And when we look specifically at procedures, there was no statistically significant difference between ASCs and office-based settings in events after miscarriages treated with procedures. While the safety of miscarriage treatment does vary slightly across settings, findings do not support limiting provision of miscarriage treatment to particular types of settings. Taking a step back, looking at the body of research that I just shared with you, we found no statistically significant differences across ASCs versus office-based settings for procedure-related events. This is consistent with research that compares the safety of other outpatient procedures across ASCs versus office-based settings. We did find that miscarriage treatment-related events appear considerably more common than abortion-related events, but that evidence does not support limiting abortion or miscarriage treatment to a particular facility type, which is consistent with the National Academy of Medicine conclusion. The last study that I'm going to tell you about is a study that we call Research Evidence and Facility Standards. For this study, we looked at what processes were used to develop facility standards for other outpatient procedures, including endoscopy, oral surgery, gynecology broadly, and plastic surgery. And then how is research evidence incorporated into these processes? To do this, we reviewed published documents and conducted key informant interviews. What we found was that in terms of processes, usually groups of clinicians involved in large professional associations or accreditation organizations review existing guidelines related to a topic. They search and review published literature, assess the quality of evidence, describe what the evidence indicates, and make recommendations. We did find that one association conducted a systematic review and used a rigorous virtual consensus process. But we found that these standards are not typically based on a systematic review, and that's mostly because the research evidence directly answering the relevant questions does not exist. Accreditation organizations may incorporate quality improvement data. We also found that some groups are trying to become more evidence-informed, but in the absence of research evidence, committees setting facility standards rely on their clinical expertise, their sense of best practices, and provider feedback. And consistent with Dr. Swartz, what Dr. Swartz mentioned in her presentation, they focus on ensuring that standards are not more burdensome than the procedure requires. In terms of some conclusions from the REF study, it is typical to have those who perform a procedure involved in developing guidelines for patient safety. Evidence for research matters, but it's not realistic to expect a clear answer from randomized controlled trials. And in the absence of evidence, the balance of patient safety and the burdensomeness of the requirement needs to be considered. And it's important to rely on the expertise of clinicians involved in performing the procedure. Relevant to the broader question we're here talking about today, a group of clinicians came together and published facility guidelines for the safe performance of primary care and gynecology procedures in offices and clinics. This set of guidelines focuses on primary care and gynecology procedures and includes abortion. This process was led by ACOG and the National Partnership for Women and Families, and has been endorsed by multiple different healthcare provider groups, including physicians and nursing associations. Before we turn to questions, I want to turn us back to the policy context. Because while our presentation has very much focused on describing and then applying professional standards related to how to approach conducting research and developing guidelines that are based in evidence for facility standards that apply to abortion, we're not operating separate from a policy context. There are two recent relevant Supreme Court cases that are highly relevant to this work. One of them is a Supreme Court case that was decided in 2016 called Whole Women's Health versus Hellerstedt. This was a Supreme Court case about a Texas law that required abortion facilities to meet the standards of ambulatory surgery centers and required abortion providers to have hospital admitting privileges. The Supreme Court ruled that that law was unconstitutional, and in their ruling, they emphasized the importance of considering research and credible scientific evidence that related both to whether there were benefits from the particular requirements as well as what the burdens were. And so going back to the research that we shared with you today, questions about benefits would be whether any research evidence indicates that they would improve patient safety, and burdens would include questions of whether or not they decrease availability of abortion services. The Supreme Court considered this similar question again, this time about a Louisiana law. They just decided this case, June Medical Services versus Russo, at the end of June. This was a Louisiana law. This was about a Louisiana law that required abortion providers to have hospital admitting privileges, and it was the exact same requirement as they had considered in the Whole Woman's Health versus Hallerstadt case. Again, the Supreme Court ruled that this law was unconstitutional. However, the way that they wrote their ruling, or the way they came about the decision, raises some questions about whether laws, the benefits of laws will need to be considered in future decisions about whether particular laws are constitutional. So that brings me into a brief discussion of what our roles are as public health or healthcare professionals more broadly can do given where we are. So from research that we did about how public health professionals and health departments approach abortion, my colleague Nancy Berglass published a paper that found that there are 3 different ways that public health professionals and health departments engage with abortion. First, they implement what they are legally required to do. Second, they bring public health approaches to what they're legally required to do. And third, they implement public health-oriented activities using accepted public health approaches. For this second one, and this is the one that I want to highlight here, since I think this is where findings from our presentation and webinar today are relevant. One way that public health practitioners in health departments bring public health approaches to what they're legally required to do is work to ensure that any regulations that they are implementing are based in the best available research evidence. So the research evidence that we shared here today is relevant to questions of how health departments regulate abortion facilities. We've synthesized that body of evidence, and we have created a website that is about outpatient facility regulation, what the evidence shows, and you can find that on the UCSF website. And one concrete suggestion for ways that health professionals and health departments can engage with abortion is by reviewing, discussing, and sharing relevant research evidence. And now we have time for questions. Thank you.
Sarah and Alicia, I have one question. It's how might facility survey agencies and nurses use this evidence?
Sure. Thank you for that question. I would say I think the first thing is reviewing it, becoming familiar with it. I think the second piece is sharing it with others in the division, and when possible, sharing it with people more senior in the department. And I think that working to ensure that regulations and policies are based in the best available evidence is always a role for people in the health professions. And then I think the other piece is when inspecting abortion facilities, what's important to remember is that sometimes the regulations are not based in the best available evidence. And so being aware of how that shapes the interaction between inspectors and abortion clinics is incredibly important.
That appears to be the only question at this time.
Sarah or Alicia, is there anything that you would like to add?
I think the only thing I'll just say is that, I think we also looked at accreditation body standards, and some office-based surgery laws also included abortion in their office-based surgery laws. And I think in the review of the state laws and the accrediting body requirements, we just saw this like dramatic difference in terms of how abortion facilities are regulated. I think it's important to keep that in mind and think through ways in which abortion facilities are regulated in such a way that it is inclusive of other types of procedures and the nature of the procedures that those facilities provide.
In terms of an additional response to the question, sort of thinking about how nurses are trained in the data around the appropriate methods for inspection and regulation of abortion facilities. I'm really optimistic that as we go forward and we are thinking about the expanded role of nurses in sexual and reproductive health, that our educational institutions of nursing begin to expand their training so that nurses come out of programs with an evidence-based sort of baseline of information that they can take out into the field and take on a new profession as like an inspector of a facility or be on the board that's setting policy and procedures for outpatient clinics, specifically for procedures that are as low risk and as safe as abortion procedures. So I remain very optimistic that and very happy that these data are being collected and that they're being shared in this way, and optimistic about nursing as a field in its entirety, expanding its scope to address some of these issues.
If there are no other questions, I will offer just a few take-home messages to summarize what we talked about. The first take-home message is that health professionals should approach abortion using values from their professions, including the best available research evidence to guide policy and practice, and values related to nursing in terms of obligations to caring for the patient. The research clearly indicates that abortion is very safe, and that is what the National Academy of Sciences, Engineering, and Medicine has concluded. And it's also important to keep in mind that the reason that health departments are newly having to regulate abortion facilities is not because of a new patient safety problem in abortion clinics, but because politicians have decided to use the public health infrastructure to implement politically motivated abortion policies. And public health professionals and nursing professionals and health professionals more broadly can continue to learn about and share and disseminate the best available research evidence. Thank you so much.
Thank you, Sarah and Alicia. AFSA would like to say thank you to you guys for your presentation and advancing new standards in reproductive health. This session has been recorded and will be available to the AFSA membership within a week. Thank you so much, everyone.
Thank you.